Thank you so much to our interpreters for being able to do this and provide this service, especially for people who are bilingual or multilingual. Hi, my name is Coney. I'm the Hep Connect coordinator with the North Carolina AIDS Action Network. And today we will be talking about successful harm reduction in the times of COVID-19. Our last group wasn't nearly as big, so we won't be able to go through and do individual introductions, but if you would feel free to be in the chat and to say your names, pronouns, organization affiliation, and your favorite song. Feel free to add that to the chat. And also, when you go through and you have to ask a question at the end of our Q&A session, also feel free to reiterate that when you do speak. That way, interpretation services are able to make sure that everyone knows who's talking. So without further ado, let's go ahead and get started. So, as I mentioned, COVID-19 has brought some unprecedented changes, and it's been a lot for a lot of organizations, especially with harm reduction. You're having to do harm reduction on top of COVID harm reduction, on top of so many other facets to harm reduction. And there's still people out there who are doing the work and ensuring that services are available and accessible to the people that need them. Especially when things such as isolation is encouraged through social distancing. So we want to take the time today to talk to them, learn from them about what they're doing, and hopefully incorporate some of their practices into our own daily lives. Today with us, we have Michelle Matthis, we have Jacqueline Fox, Andrew Kiles, and Lisa Macon Harrison. I won't go through too many details about who they are. I'll let them introduce themselves, and I will go ahead and have Michelle start, if that's okay. So if you could tell us who you are, your pronouns, the organization you're with, and the work that you do.
Hi, good afternoon. It's so great to look out on my computer and see so many familiar faces, and even more exciting to see faces that I don't know, which means that there's more people in this work that we get to meet each other. So I'm excited about that. My name is Michelle Mathis, and I am the co-founder and executive director of Olive Branch Ministry, which is a faith-based organization. We do faith-based harm reduction based in Hickory, North Carolina. We serve 9 counties in the Piedmont foothills area of North Carolina. I'm also the board chair and interim director of the North Carolina Harm Reduction Coalition. My pronouns are she, her, hers. And again, I'm just thrilled to be here.
Thank you so much, Michelle. I'll hand it over to Andrew and Jacqueline. They're both sharing a screen, so if you only see one screen, that's what's happening. So I'll let you all take it away.
My name is Andrew. I'm a community care paramedic with McDowell County EMS. And just briefly, what differentiates between a community care paramedic and just a regular paramedic that's on a truck, I work out in the community, just in a SUV vehicle that's equipped. I deal a lot with psychiatric patients, overdose patients, substance abuse, and then overall just high utilizers of 911. That may have difficult home situations. I help them get set up for success so that they don't necessarily need to use emergency services quite as well. That helps just on a local level with ambulances, and also helps up higher up with ERs, keeping rooms open for patients that are actually in need of emergency treatment and services. I work hand in hand with Jacqueline a lot with peer support services, following up with patients, transporting patients to detox facilities, rehab facilities. Then also myself and another individual, we're here every day. So anytime Jacqueline's not around or she's off or busy, she can contact us and we're able to communicate with those patients. And my pronouns are he, him.
Hey guys, my name is Jacqueline Fox. I am the team lead for McDowell Impact Peer Support Services, and I work mainly in the EMS division. So I follow up with patients who experience overdose or have substance use mental health challenges, and help get them connected to services. We do a lot of Narcan training and distribution to the public here in McDowell. And like Andrew was saying, I work alongside these community care paramedics to respond to these patients, or peers as I call them, to help get them followed up with, so that they're not just being revived and then kind of left on their own. They have someone to walk alongside them and help them navigate that experience or any kind of resources they may need afterwards. And my pronouns are he, her. She, her. My bad.
Thanks so much, Andrew and Jacqueline. And Lisa.
Hi, everyone. I'm Lisa Macon Harrison. I'm a local health director at Granville Vance Public Health. Both Oxford and Henderson are the towns where we have local health department services available. And then, of course, with outreach all over those two counties in different spots. I identify as she, her, hers. I work with an amazing group of people inside our health department and also partners outside our health department, like Harm Reduction Coalition. It's so nice to see Michelle's face. We work a lot with people who are in our two counties doing the work of harm reduction around medication-assisted treatment and group therapy and integrated care, as well as full spectrum primary care. We're so lucky that we also have a lot in that regard. So I'm happy to be with you today to sort of talk about all of that. My favorite song right this minute is a song entitled Turn Off the News and Build a Garden. It's a fun song. If you haven't heard it, it's like Willie Nelson's sons sing it, and it has the best lyrics about how to deal with stress right now and just not pay attention to the news if you can.
I will definitely be heeding that advice and starting my own little garden here pretty soon, weather willing. So thank you all so much for introducing yourselves. I'll go through and I'll ask the questions, and we'll go pretty much in that same order. I'll ask the question and then Michelle can answer, Andrew and Jacqueline, and then Lisa. And so one thing I'm really excited about with this workshop is that you all do a lot of different services to a lot of different counties. So you're actually pretty well spread out throughout North Carolina. So to start off, I would like to ask, could you describe some of the unique challenges that come with providing harm reduction services to the populations that you serve in your part of the state? And again, we'll start with Michelle. You're still muted. Sorry.
Hold on. There we go. Sorry. We serve mainly rural communities. So our territory is, I'm just going to run through the counties real quick. Ashe, Allegheny, Watauga. If you come down Highway 321, we skip Caldwell. We do Catawba, Burke, Iredell, Lincoln, Gaston, Cleveland, with carryover into Rutherford. And we have a few folks, I know somebody from McDowell is here. We have a few folks that come from McDowell to us as well, but they come across the county border. So that's our expanse in our little neck of the woods. Very mountainous in some particular areas, but extremely rural, with the exception of Gaston County. And even some of Gaston is rural. So that has been challenging because a lot of what we do is mobile exchange. We have 3 fixed sites, one in Lincoln, one in Gaston, one in Catawba, and one in Cleveland County. And so folks can come to us. The challenge for us always has been meeting people. For lack of transportation, many of the areas that we serve don't have public transportation. Folks can't get to us. So we have to figure out the best way to meet people and also be discreet about it, because being in rural communities in the South, everybody knows what everybody's doing. You know, everybody will tell your mom and them they saw somebody pull up, you know, in a big van or a bus or whatever. Or if we go and park somewhere, people are wondering who's coming to your car and why. So that has always been a challenge for us. And I think we have accommodated it well in that we use very discreet vehicles. They're not marked, and, you know, we're able to go to folks that way. So that's a challenge. The other challenge for us, I think, is that um, because we are a ministry and it's in our name, even though we don't evangelize, our faith is our why, but it's not our what. So, it's our motivator. That some folks are hesitant at first, not so much in the rural communities, but in the Gaston area, and even a little bit in Cleveland. They were hesitant at first because they thought that we were going to try to tell them that using substances was a sin and that they had to find Jesus and leave the needle. And that has certainly never been, nor will it ever be, our message.
Thank you for that. Discretion is definitely one of those things that doesn't always come to mind, for me at least. So like you mentioned, having unmarked cars, especially if they know your organization, it's like, oh, well, I know what that person's doing. Definitely not things that I think about. And it is also interesting that we want to have more faith-based help in this work. So to understand where that pushback comes from, yeah, it's very essential. Thank you so much for that. So same question to Andrew and Jacqueline. Could you describe some of those unique challenges that come with providing harm reduction services in your part of the state?
So a big one with emergency medical services is no one really kind of understood how far behind we were in regards to personal protective equipment and just overall our physical interaction with patients. So our level of PPE has increased greatly with any type of patient contact, and even when we're in contact with each other. So that also goes with now our stations are much more contained and locked down. Bay doors stay closed, doors stay locked. Even we're in our main office, and during the week, it's packed with people, but now it's just typically me and Jacqueline sharing the office, and the door is locked with a sign saying no one's here, contact this number. So that's also discouraging to a large homeless population that exists within this area. They're no longer able to just come up and freely knock on the door, directly able to speak with someone. And then if it's someone that doesn't really understand the extent of services that we provide through peer support and community care paramedicine, say a paramedic that's just solely focused on their patient care, these patients may even be turned away by saying, due to COVID precautions, you can't be coming around the bases and that type of thing. And that also extends to when I'm out in the field. Say, for example, I'm trying to deliver food from a food hub to a individual that's living under the bridge and hasn't eaten in a couple of weeks. It's hard for me to try to connect to this person, but at the same time explain to them, okay, you've got to stay, you have to stand back over there, or here's a mask, you've got to put this on. Because to somebody that doesn't have a roof over their head or doesn't know when their next meal is, wearing a mask is the least of their concerns. They're just trying to survive day to day. So it's, with all the precaution and all the new mandates that are coming down for us, it's hard to relay that to this population of people that, we're now struggling, hoping that we don't contract a virus that could potentially put our life in jeopardy. That's how they've been living for years, of day to day. So that's been the kind of the biggest adjustment of new policies that have come down on the EMS side of things.
And so, yeah, I would agree with him. Our outreach programs, events, destigmatizing campaigns, things like that have really taken a big hit. We used to go out into the community weekly just to bring Narcan and food boxes, hygiene items, whatever we could to folks. And that would sometimes create a crowd around our vehicles. And we can't do that right now because of COVID. So we're having to kind of, like Michelle was saying, be a little more discreet, a little more one-on-one. So our capacity is more limited now, to have to make the time to kind of go out when we can and one by one to meet these folks where they are. And we keep tents and sleeping bags and Narcan here. So like Andrew was saying, people just being discouraged to kind of just come up and be able to get these things. It just puts a lot of extra work and stress on the community care paramedics, the peer supports that work with me, just having to make sure these people still have access to these simple basic needs. And I just feel like a large part of the disease of addiction is isolation. So we're kind of buckled in the substance use mental health world, because that isolation and lack of connection is going to continue to put a strain on folks who are already living under those kind of circumstances. And maybe when they're reaching out for connection now, it's harder to find. So that's definitely been a change. But I won't go further because I know there's more questions, but I'm so proud of my peer supports and the agency I work with at just knocking down those barriers to still stay focused on the priority, which is the patient, the individual. I'm sorry, I keep calling them patient because EMS, but the peer or individual, and what they need. That's the priority despite the challenges.
Thank you for that. Yeah, I can imagine it being very hard when you've got that relationship built where they can just come up and they'll see you or they'll talk to you, and then it's like, well, that's no longer the case. You can't do that anymore. It really does. It's kind of hurtful for a lot of people. And thank you also for bringing up the fact that the pandemic stress may be new for some of us, but for some of the people that we serve, it's been an everyday thing. And that's a very strong reality to accept. So yes, thank you so much for pointing that out. And Lisa, same question. Could you describe any unique challenges that you're facing serving the populations in your part of the state?
Yeah, definitely. So Vance County has approximately 40,000 people in it, and Granville County has closer to 60. So together, our district health department serves about a population of 100,000. And I think the unique challenges are not unlike other places in rural. I think Michelle's points about her experience working with rural, where everybody knows everybody, and there's a big influence from some faith-based traditions and some traditions of um, I guess a little bit more in the South and the Bible Belt. There's a lot around judgment that we have to work through. And I think what harm reduction brings to us is this more acceptance and meeting people where they are and not placing any blame. And I think that's a culture change that we're having to drive and lead and make daily with staff and partners. Some reminders about what harm reduction is and how harm reduction is working differently than an all or nothing approach. There's so many treatment centers and there's so many healthcare centers that really are abstinence only when it comes to providing treatment for mental health, substance use disorder, and lots of healthcare issues that we see in primary care. And it's just so limiting. So I love that the harm reduction approach is where we are and are moving towards still, but it definitely takes a consistent approach to making a culture of harm reduction accepted and really influencing partners. We were really lucky at Granville Vance Public Health. We had a harm reduction coalition person come to us and say, look, we've got a lot of work to do together, and your priorities are mental health and substance use disorder. You're starting primary care. We could really work together and do this harm reduction thing. So we had to sit down with our partners and apply for a grant because, of course, in a poor rural area, funding is a huge barrier. Even for those of us who have regular connections to local, state, and federal funding, it's never adequate. There's always more to do that you have money for. There's always more grants to write. So we combined efforts, and the first grant that we wrote to address mental health and substance use disorder that was really successful and had a lot of partners at the table was a HRSA grant called a Rural Opioid Overdose Prevention Grant. And it gave us our first $150,000 to work with to be able to really prioritize the work, to hire some extra folks, to contract with Harm Reduction Coalition. And I think local health departments really need partners who are boots on the ground, who know how to go into shooting galleries and address connection and build trust and hold our services in high regard. You know, local health departments have been around in North Carolina for more than a century, but we've not always had necessarily the best reputation among all populations. We have, you know, good leaders and indifferent leaders and leaders that need a lot of work across the state. And so we have to work with partners to be able to get around some of the bureaucracy and some of the traditional thoughts people have around what a local health department can do, and try to forge new pathways and new ways for people to trust us and seek care with us, and a new culture, like I said, organizationally, to be able to do harm reduction well. So our other unique challenges, other than funding and certainly working through those partnerships and building trust, is transportation. I mean, in a poor and a rural area, getting people to know how to access your services is tough. So again, being able to meet them where they are, both literally and figuratively, is critical. Knowing how to get to the places where people need you to be in order to provide education and resources and services really is critical. So I think those are most of the challenges that everybody's probably already familiar with, but those are the ones that really hit home for us.
Thank you for that. Yes, transportation does seem to be like a universal, at least in this state and some of the other states that I've lived in, it's a universal need. And also bringing up funding, yes, trying to get funds to do things is essential. So thank you also for bringing up that point too. So you've all talked a bit about the different types of work that you do and some of the unique challenges that you've had to providing services with that work. I would like to talk a bit more about some of the trends that you see amongst the people that that you serve that require immediate attention, and how you think those trends came to be. And again, we'll start with Michelle.
I think for us, isolation, I won't call it a trend, because isolation for us is a way of life. Again, because some of our folks are so spread out. And I mean, literally, when you have to drive through a cow pasture to get to someone's, you know, trailer that they're living in, that's pretty isolated. Public transportation doesn't go there, right? So isolation is, for us, is not a trend. One of the things that we see here that we've seen an increase in is polysubstance use. Because, and that is a historical trend in our particular area. Hickory is known as the furniture capital of the world. And the reason being is because before a lot of manufacturing jobs went overseas, we would see, you know, piecemeal work all in the surrounding counties. Piecemeal work being, for those of you who aren't familiar with it, you literally get paid for the pieces that you make. So people would operate from their homes. They would have a sewing machine or a workshop or whatever, contract with a company, and they would at the end of the week take in their pieces, and that's what they would get paid for. So it started off with people using uppers, using, you know, meth, using anything they could to stay awake for days on end, in order to be able to generate more pieces of manufactured goods in order to provide for their families. And then they would crash because they'd been up for days, and use opiates or other downers, really, to cover pain of being up that long, helping them sleep, and then the cycle would start all over again. So we see that, which started in a history of our manufacturing community, has now become generational trends within families. It is a way of life. So that has been interesting. And for us during COVID, we've seen an even more of an increase in polysubstance use. That has not necessarily become because of the historical reasons that we've seen it, but now it's because of lack of supply. So we've seen things like a drastic increase in dirty 30s, blue Roxys that are in our area, that people are passing out at gas pumps, and while they're pumping gas because they've taken them, and huge number of overdose increases. So along with that, we've seen a big trend and an uptake in the need for Narcan and naloxone. And so I think really that's been the biggest thing. The other thing, which is a really, it's an awful trend, but it's a direct result of COVID. I heard, the EMS folks mention, them having to change their protocols. Except for wearing PPE, we have not changed our protocols. We've continued to meet people face to face. We've continued to, carry on as usual, just adding PPE. But what we've noticed is that organizations like EMS, and I'm not saying y'all, I'm just saying the counties that we work with, that we have overdose response teams in, their increase in concentration on COVID has decreased the number of referrals that we've received, even though overdoses we know for a fact are up. And with the hospitals, it's next to impossible to get into a hospital, into an emergency room to see one. And we are a direct response overdose response team, which means we're used to going into the emergency room, sitting bedside with that individual. And then even if they're transported to a floor for additional medical needs, going up and making visitations in the hospital. And 2 of our hospitals have completely shut that down, where we're not allowed to come in. And so that has changed the way that people who can access our services who've experienced an overdose has been greatly decreased. And then our ability to reach back out to those that we are aware has been decreased as well.
Ooh, I'm just going to take a minute because that was a lot.
I'm sorry.
No, I really appreciate it. Yeah, especially with understanding the historical piece that in rural areas, isolation is a part of life. It's not necessarily a trend that you see, and understanding how substance use came to be really just a part of the historical piece of whatever county you're serving. Real quick, before I ask our next presenter, would you mind telling me what dirty 30s and blue Roxy's are? I've never heard those terms.
It's a street pressed pill that are being sold as Roxy's, but they're blue, and they're 30 milligrams. And so that's just what we know. They're being, a lot of times we've seen stuff coming into our counties, but we know for a fact that these are being manufactured in at least local supply in Cleveland County. We've also seen a lot of overdoses up in the mountain counties that have been reported down to us. And we put out bad dope reports whenever we get those, but now we're also seeing them in Gaston County, Lincoln County, Burke County, McDowell County. I don't know if y'all have seen those as EMS folks in McDowell County, but we're seeing those on a great increase.
Oh, okay. Well, thank you so much for explaining that and giving us some historical background too, especially with not being able to be in the hospitals to help people as they're making their way through this transition. So same question for Andrew and Jacqueline. Could you talk about some of the trends that you might see amongst the people that you serve that require immediate attention, and how do you believe that these trends came to be about?
So it's kind of a weird thing to think of as far as trends increasing in a pandemic state, because with emergency medical services, people are going to still get sick. People are still going to get injured, and we're still going to respond to those calls day in and day out. I would say the thing that needs immediate attention is, even, however many months we're into this, 6 months later, is education, because I'm still dealing with large quantities of people that just think that because they're not directly affected by this pandemic, it's nothing significant for them to really worry about. For example, yesterday I went to test a group home who an employee had tested positive, so they wanted the entire group home to test. And when I'm there dealing with residents where a positive COVID individual has been, nobody's wearing masks. If they are wearing masks, they're not being worn properly. So it's a matter of people just not taking this seriously still, which is having that chain reaction of, I ended up testing two people in that group home ended up being positive, and had there been more precautions in place, that could have potentially been avoided. And that include one individual that was just blatantly not wearing a mask that also worked for a nursing home in the county. So you have to assume that that's being spread around, and not only to themselves, but their family members, to their coworkers, to their patients. So I'd say the immediate need is just continued education with, talking about overdoses. We are seeing a uptick over the past month. I would say we're averaging probably 3 to 5 a week at this point. But a great resource that we have is on every ambulance, on my vehicle, on a supervisor's vehicle. Jacqueline carries the same. When we go to a patient's residence and we're able to get them back with Narcan, and they either refuse or they're transported to the hospital, we're able to leave Narcan with them in the house, just to have. And it's a quick explanation, self-explanatory use. So that's a great resource we're able to provide to the county and its residents, which has really come in handy, especially over the past month.
Yeah, so for my side of things, in the beginning of when COVID all started, we seen a decrease in engagement. People just weren't engaging in services. It was really hard to adjust to like a virtual platform. But like Andrew was saying, lately we have seen the increase in overdose. We've seen an increase in homelessness, just an increase of folks dealing with stress and anxiety, and folks who are just kind of at the end of their rope. They may have been living, on the streets for this amount of time, and the added stress and the added isolation, they're just kind of really needing connection and support. So I'm seeing an increase in engagement, and an increase in folks willing to seek some sort of treatment. So good and bad trends. The thing that needs immediate need is definitely the increase in overdose trends, because that's such high risk. And I think also the increase in homelessness, the housing crisis that we're all too familiar with, definitely needs some attention. And that is those barriers, the lack of funding, the lack of resources. We're a small town, we're very resource poor. So that's the kind of things I've been seeing on my side.
Thank you both for answering. When it comes to taking COVID seriously, I think that some of the ambiguity around the messaging that we've seen locally, at a state level, on a federal level, has definitely caused some anxiety. And so really trying to grasp that as a consumer definitely causes some anxiety. And again, like you mentioned, the Maslow hierarchy of needs, like having safety, having food, having shelter, those things are essential in order for people to want to access services. It's kind of hard to want to access things that are important for you, but you have all these other major needs that need to be addressed first. And so same question to Lisa. What are the trends that you've seen amongst the people that you serve that require immediate attention, and how do you believe those trends came to be about? And also thank you, Jacqueline, for making a point that there are also positive trends too. So yes, feel free to add on that.
Yeah, definitely. Those were all answers I was nodding my head to, and will second each of them. I do agree with isolation and sort of the stress around COVID has definitely been felt by everybody, and we see those trends play out in people trying to seek care and then running into barriers for seeking care because of so many places limiting exposure right now. And that includes a local health department. So we try to do screening on the phone. We try to do telehealth whenever we can. And we are just so fortunate. We have a full-time medical director named Shauna Guthrie. If you were on last night for the reception, she was on briefly as she was traveling. So she's not able to be with us today, but she is just an amazing, young, energetic, not afraid of trying things new kind of physician who really loves her patients and builds trust quickly and easily with almost anyone. So I think that's a helpful relationship that people have built. And so they will still seek her care and counsel via telehealth. Not everybody's as comfortable with telehealth services, but we are definitely seeing the trend of more people connecting that way. We've tried to we offer group therapy around medication assisted treatment. And so we're even trying to offer the group therapy in forms like this, which is different, and not everybody loves it, but some people actually do prefer it because then they don't have to worry about the transportation. So if they do have a smartphone or a computer, or access closer to their household to a smartphone or a computer, sometimes that's easier than catching a ride into town. And so that can be, the silver lining option, like you were saying. We'll focus on the positive too. Trends of overdose and trends of polysubstance use, we definitely see, like Michelle mentioned, and I know our EMS friends are seeing too, and that's hard. I think the other trend that I wanted to mention that just hasn't been mentioned as much before is the trend around ACEs and trauma that continue to feed the people who come to see us and need healthcare services and need integrated care, need behavioral health services, need substance use disorder counseling, have all experienced either adverse childhood experiences or more recent trauma as adults. And I hate seeing those trends, but they're very familiar to us. And a lot of times, Dr. Guthrie will even provide services to multiple people in a family unit. So we'll be addressing substance use disorder in a grandmother and a grandchild, or in an uncle and a nephew, or in sibling pairs. It's interesting to me how out of the medication assisted treatment patients that we have, how often there are relationships among them. And so we don't advertise our services. It's all word of mouth, and it's all connecting the dots to people who need services. And I saw some in the chat about questions around trying to address those who have overdosed, who have presented to an emergency room and have gotten Narcan and have recovered. How do we get them into the fold of recovery and options that they have resources and people who can try it to address some of their challenges and social determinants of health, like housing and the things that we've heard already. But we do also have a post-overdose response team. I think, Michelle, you had mentioned a post-overdose response team or a PORT. And we are always working together with our local EMS and law enforcement and hospitals. We uniquely, in a rural area, we actually have a hospital in each county. We have a hospital in Henderson and a hospital in Oxford. And so we've built relationships over the last 8 years with both, just trying to ensure that peer support can get into the hospitals and address people who have had an overdose experience, so that they know we offer medication assisted treatment. They know that there's help. They know that there are resources available for them. So that's helpful. We haven't gotten the science down just perfectly on that yet. It is, you have to be careful about privacy issues and HIPAA and anonymity, that people want to remain, with careful connections there. But at least people know that they can be referred to us, and the emergency room staff have been good about helping with that. So there are some things we're doing to put in place to address these trends, but I do think COVID is making the trends that we see around disparities, that we see around social determinants of health, that we see around trauma, much more difficult to get through, but we've got to keep trying.
Thank you so much for that answer. Especially with talking about telehealth. I know a lot of people, in our last workshop, we talked about how telehealth appointments for Hep C have become more popular. So to see telehealth with harm reduction, that sounds like a really good positive thing to be able to incorporate. And to bring up ACEs, to the adverse childhood experiences, and how that really can be generational trauma, and how you really could be assisting an entire family across several generations. Definitely something that is important to consider. I do see that we have some questions in the chat, and although I would love to ask them, I will probably have to hold off and ask them towards the end of our discussion. So as soon as the questions are all asked, I will go through those chat questions. So feel free to ask questions in the chat. So a follow-up question, that I would like to bring up after we've all talked about that is, what services have been in higher demand since COVID-19, and have you been able to meet those demands? And I'll start with Michelle.
I mentioned earlier, we've had a great increase in the need for Narcan and naloxone. Part of that is because overdoses are up, and part of that too is because people who may have called EMS in case of in the case of an overdose are no longer wanting to do so, and it has nothing to do with EMS. It has to do with the fact they don't want to, because of the virus, they don't want to bring other people into their homes. And so when an overdose happens, there's lots of folks that arrive on the scene, and so they don't want folks coming in. And so we've seen an increase in that. For us, in some of our areas, we've also seen a great increase in the number of syringe access folks that have come to us, who may not have originally been participants in our program, but because there's other agencies in the area who were providing syringe access, who for whatever reason have limited or cut back their programs due to COVID, they're coming to us. So we've seen a big increase in supply requests, something we didn't budget for. So we've had to move some stuff around because it's been pretty significant, but we're happy to help. And I am proud that, there's just 6 of us that work for Olive Branch, but none of us have gotten COVID. We've all been able to maintain our offices, and so I think that an increase and a higher demand on our staff has been there. And I don't think we often think about that. We think about what services, but our services also increase the demand on our staff to be present, to be available, to be ever vigilant in protecting themselves, even more so to make sure that we don't get our program participants sick. So, we think about demands from those that we serve, but there's been a lot of extra demands on those that are doing the serving as well.
Thank you. That is an excellent point. And it's one that I've been trying to put in at the end of my email signature, like, don't forget to practice self-care. I can imagine that all of you are probably really overwhelmed, especially with some of you serving multiple counties. I can imagine that's really overwhelming. So yes, self-care is essential in a time like this.
I've made sure that our staff take at least one mental health day to do nothing, and that means no checking phones, no whatever. And it's a paid mental health day because they need to take that time for them.
To the people, we appreciate you. Okay, so yeah, same question to Jacqueline and Andrew. What services have been in higher demand, and have you been able to meet those demands?
So right off the bat, a service that's been in higher demand is peer support and community care paramedicine. Our community care paramedic program has grown exponentially during this time of COVID, due to the fact that if I can respond to a residence, whether it's a high utilizer or an unknown problem due to a subject laying on the side of the road that's just taking a nap, and I can keep an ambulance crew from leaving this base, I'm then cutting down the risk of 2 people just to myself going out. Because, while it is very hard to adjust to hospital ERs and EMS bases becoming less approachable, the purpose is for that. Like here at McDowell, we have our set full-time staff. Part-time staff members are not required to work. So if a full-time staff member goes down, now you're potentially looking at having to shut an ambulance down. And for a county of 40,000 people, we only run 4 ambulances at a time. So we have to be very disciplined and strict on what we're allowing these ambulance crews to respond to put themselves at risk. So how we counteract that is with our community care program. We now run a community care paramedic 12 hours every single day, 7 days a week from 10 to 10. And so that covers our high utilization times of morning, lunch, evening, and then our part of the early nighttime, which so it's been a huge success and is really allowed for less pressure to be taken off of these ambulance crews.
So on my side of things, and I know I keep going back to the connection piece, our peer support team has kind of been scrounging to make sure that groups are happening, people are able to somehow get together, somehow get face to face with a support person, and also just a greater need on programs like ours to work really hard at communicating with partnering agencies so that we know what their barriers are, what their restrictions are, and just to keep that continuum of care, that communication going for these folks, because there was kind of like I mentioned earlier, there was in the beginning a decrease in engagement and just a lot of confusion. So we all kind of had to step up and say, okay, what are you offering, and what are you doing during COVID, and what's like, for instance, getting someone into treatment programs, what do they need prior? Well, the newest thing is they need a COVID test. So working with EMS, and we're just fortunate here because I'm embedded in EMS. I'm I'm actually and certified EMT. So I'm able to go into the hospitals. I'm able to build on that communication. And we work closely with public health. We work with the health department here, just to make sure that we know that the services that are still needed, like Hep C testing, Hep C treatment, peer support services, Narcan training and administration, even to all these agencies, is still happening. So we have just had a lot laid on us because there's this whole huge pandemic that we're all addressing, we're all working towards, but there's also a pandemic that's been going on for years. And there's also people still dealing with being diagnosed with Hep C. And there's also people still living in isolation. And I feel like all of us, especially in this meeting right here, are just people who are kind of called to meet those needs. So we don't quit trying to meet those needs. So just partnerships is the greatest need here. Our DSS peer support has seen an increase in the need for peer support services there. She works with families at risk for foster care placement, and she's just been really overloaded with folks and having to put people on a waiting list because there's only one of her down there. There's a lot of stress with folks not being able to do as much visits because of COVID. So just more capacity for all these agencies working on the front lines of this thing and providing all these amazing services like harm reduction and like peer support and medical, all this stuff, just continuing to communicate and understanding what each one of us is going through so that we can be more united.
That was excellent. Thank you so much. Yeah, community support is definitely something that's very much so needed right now. I like to say that the burden is not ours to carry, but it's ours to shoulder. So we should at least try to put a shoulder underneath it in any way that we can. Especially with having your hands in so many pots, I can imagine that being stretched thin is a, a regular reality at this point. And also, thank you for talking about the COVID-19 requirements for getting in-person services for some people. That's not something I would have thought about. So yes, thank you. So Lisa, again, what services have been in higher demand and you're part of the state, and have you been able to meet those demands?
Yeah, so we've seen sort of a roller coaster of demand, really. At the very beginning of the pandemic, I think people were doing a really good job staying home and also wanting to avoid any healthcare entity at all, as was understandable. I think over time, we've been able to slowly start different clinics back up again. And so we regularly have demand for primary care and for COVID-related visits. And sometimes during the COVID-related visits where people have questions as a contact to a positive COVID patient or seeking a test, we'll also meet with Dr. Guthrie about everything else going on with them. And so she kind of uses the the entry point to talk about health as what's going on related to COVID, but then we see also that there are still persistent needs that people have beyond that. And so I really, again, have to point to the telehealth option as being really helpful to us. And I do hope that that persists as an option for people that's paid for by Medicaid and other insurance companies, and that we're able to find grants to help pay for the uninsured in ways that we can continue to utilize that program. I think the other needs that have been interesting around mental health and substance use disorder is certainly we've worked really closely with the jails to try to make sure they have good infection control locally. Dr. Guthrie is also the jail medical director in Vance County. And so we have, between that relationship and also our Stepping Up initiative, which is an initiative across a 5-county region that we lead to try to address mental health and substance use disorder in the jails. We have great working relationships with our jail administrators and magistrates office. And so there's a continual need to work with them and make sure that people are getting the services that they need. And interestingly, during COVID, we've actually started a program from our dental clinic where our dentist will go into the jail, because people don't want to expose individuals and bring them outside of the jail. They also don't want to isolate them, but they want to sort of keep the pods safe and infection control oriented. So our dentist has been traveling in and providing dental services, which is a unique new service opportunity that we hadn't thought of doing that way. We're used to seeing people from the jails into our dental clinic, but because of COVID, we're doing the other direction. And that's just an interesting thing that we've started service-wise that's going to look a little different for right now, just to keep everybody as safe as possible, trying to do more mobile dentistry. The last thing I'll say is that with regard to making sure that our law enforcement partners have what they need to continue to do harm reduction, we have been placing additional orders of Narcan throughout the pandemic to make sure that our law enforcement partners have enough. They have been using more lately, and so they've run out more quickly than we've seen before, which we're sad to see. But they're good about reporting to us, when they use it. They're good about reporting to our Harm Reduction Coalition friends when they use it, and we're really fortunate that we have very positive working relationships with law enforcement. It took a while. It's taken about 5 years to build the relationship and training that we've needed to continually offer before we've had really good uptake across both counties with sheriff's offices and police departments. But I'm happy to see them reaching out and asking us for Narcan, asking us for training for their new folks, and making sure that the crisis intervention training, of course, the heightened awareness this year about how law enforcement and public health and social services can work together differently and make sure that they're for and with community differently, has been a positive in our 2 communities. I know it's not that case everywhere, but we were really happy to be able to work with our law enforcement partners and sort of make sure they have what they need, and are continually on this public health mission with us together. So that's been an interesting, 2 little interesting surprises there. Our dental clinic going into the jails and our law enforcement coming to us more. And I'll take both of those.
Thank you for that. Yes. Having social services involved in public health and building those partnerships, I definitely feel like that's so essential, and we're getting so much closer to understanding how we can make that relationship efficient and beneficial to both parties. So thank you so much for that. I had one extra question, but I really want to leave some time for audience Q&A because I know that they have some questions too. So I'll ask my final question and then I'll pass it off to the audience. And so the last question is, it's kind of a shameless plug question. Is there anyone or any agency you would like to give a shout out to for being a champion to your cause during this time of need? And again, we'll start with Michelle.
North Carolina Injury Violence Prevention Branch and DHHS. Most definitely. They have really worked with syringe access programs to make sure that we had PPE, that we've had an increase in certain types of supplies. And so that has been huge. A lot of syringe access programs those that do fundraisers have not been able to hold those, at least in person, because of COVID. And so injury violence prevention branch, infectious disease folks, they have been great. And so I can't help but give a huge shout out to them. And I would also really like to give a shout out to my local MCO, Partners Behavioral Health, because Olive Branch is not, although we are a HEP Connect grantee, and we are appreciative of that. The majority of our funding comes from contracts with partners with our MCO. So we're a little bit different in how we get our funding. And so a big shout out for them for continuing to believe in us, even in all the craziness when numbers may not have been what they were expecting due to COVID.
Thank you. And shout out to those local departments, DHHS and Injury Violence and Prevention. Definitely people that I'm hoping to be in touch with very soon because I need to make those connections myself.
Yeah. Let me also say real quick, shout out to our folks that come to us for services for continuing to be invested in their health journeys and taking those positive steps. We wouldn't be doing this work without them. So definitely that should be first and foremost.
Yes. We talk a lot about self-efficacy, but it's really hard to be motivated all the time. So yes, people continue to seek services. Thank you from us and personally, probably from yourself too. Thank you. So same question for Andrew and Jacqueline. Is there anyone or any agencies that you'd like to give a shout out to for being a champion to your cause?
And here's my shamelessness here. I think our peer support network has just been tremendous through all this. During the week, if I'm available, I try to help Jacqueline as much as I can. But if I'm not there, then she's by herself with what limited resources she may or may not have that day in her own vehicle, traveling to these shelters, to these houses, to just random trails in the woods, looking for people, trying to do follow-ups, trying to make sure they have all the resources that they need, all the while helping instruct and guide additional peer supports located at different areas throughout the county. So her level of work and her motivation and drive has just been tremendous through all this. It makes my job easier. It makes the ambulance crew's job easier because she's focusing in on people and getting them help. I apologize, I'm at work right now, so you're going to hear radio tones. Getting them into long-term help and recovery, so that in turn is helping ERs, it's helping our crews, it's helping law enforcement, because these patients are getting, on a much better path to self-care and help, and therefore by proxy they're no longer needing emergency services quite as much. So her work has just been tremendous. But overall on that, just our county in general, health department, DSS has just been doing tremendous work, and they work hand in hand through the week. We have a separate command center away from everyone else, and it's literally my director, my deputy director, the head of DSS, and the head of the health department, all working within the same office day in and day out. So it's not a matter of emails or phone calls or texts. It's a matter of looking up and direct communication to accomplish tasks and goals and stay on the same page, which I think has just done wonders amidst this pandemic. As an employee, my day-to-day life hasn't been that much more stressful because I'm under such incredible guidance and leadership and working with departments and agencies that really just make things run smooth. So I've been very grateful for that.
Yeah, I'll try not to take up too much time, but I'm just so proud of our county. Obviously EMS, the issues that they address, a lot of us see EMS as, oh, someone's hurt, so they need to call 911 and ambulance responds. They tackle every issue that comes to their county. They see it as theirs. They see it as they can be a part of the solution. So even with COVID and everything they have going on, they're still addressing issues of homelessness, issues of getting folks connected to resources, issues of substance use, mental health, Narcan distribution. Our health department is still, I mean, they're on the front lines of this thing, and they're still working hard to address. We've recently, during the pandemic, have been able to get Hep C testing and treatment for uninsured at the health department here in McDowell. Grassroots efforts and nonprofit programs like the Foothills Food Hub still going out and handing out boxes and boxes of food, making sure everyone has their basic needs met. The match program, making sure folks are getting access to healthcare, to primary care physicians, and still sending referrals for folks who are struggling with substance use, DSS. I mean, the local shelters, there's such a handful of people that are just so willing to give and so willing to step up and say, this isn't just us, this isn't just their problem, this is all of us together, and we're going to make sure our priority remains the same, and that's the health and well-being of individuals in this county. So
Thank you. Shout out to your community organizations for still providing those much needed services. And last but not least, of course, Lisa, was there anyone or any agency that you'd like to give a shout out to for being a champion to the cause during this time of need?
Yeah, well, let me echo everything everybody's already said. I mean, we certainly couldn't do this without people trusting us and coming to us for care. Our organizations locally, like EMS and Harm Reduction Coalition, and all of the partners that I'll just reiterate, you can't do this work alone, and it takes all of us. Like Jacqueline just said beautifully, I can't top her. But it did remind me that the Mr. Rogers quote about, anytime there is anything that happens that goes wrong, a natural disaster or a pandemic, one of those examples he was saying, always look for the people who are helping. So I think we do have good fortune in North Carolina to have a lot of people helping right now. And it is the honor and privilege of my entire occupation and choice to be in public health, to be able to work with people who are always helping. And so it definitely gives me a little extra energy and wind in my sails through the week to be around 82 other people every day who believe in community-based work and believe in service. And I just am amazed by them all the time. And yes, being on the front lines right now with the testing for COVID, the contact tracing, the communicable disease work, and the nurses that do such an amazing job finding people who need assistance and then connecting them to that assistance, the care management that's happening behind the scenes, like they said, with the food delivery and the housing connections and the healthcare connections. It's really gratifying to see all that is happening. It's also sad to see how much is needed and how much we still need to be doing and doing better. But the people doing the work and the heavy lifts are all the helpers in a community, and it's just really lovely to see them working together. I couldn't also be at all successful in our health department without Dr. Guthrie being the person, the leader she is, being willing to build trust, being willing to start new programs, being smart enough to just say, I'm going to go get my waiver for MAT and get it rolling. I'm going to start primary care and figure out the electronic medical record. I'm going to make sure that we figure out this telehealth stuff and get people access to the care they need regardless. So I mean, it's fun having service oriented people, and it's fun having smart people working with you. So shout out to all of them.
Ooh, thank you so much. And yes, definitely a shout out to all the people that you mentioned. And I want to take some time to shout you all out. Thank you, Lisa, Michelle, Andrew, Jacqueline, so much for taking the time to be a part of this panel and for really putting yourselves out there and doing that work. I mean, it sounds like you all are tethered at all four corners, and yet you still somehow find a little bit left in your pot to keep going. So thank you so much for that work and finding new ways to serve the people that desperately need it. So we as Lee just mentioned, we do have a closing event. I really did want to be able to have some time for audience Q&A, but we're approaching the time where we're going to have to wrap up. So real quick, did any of our presenters have any final thoughts that they'd like to say before we close out? And we can start in the round table formation. So Michelle, then Andrew, Jacqueline, and Lisa.
I'd just like to say thank you again, everybody, for being here. It's always great to see old faces and new faces. Remember, take care of yourself because we are the caretakers. And always think outside the box. That's the key to continuing services in times of crisis. And understand where as providers, it may be crisis for us, but as someone mentioned earlier, our folks live in crisis every day. So this is just one additional hurdle they're having to get over. Go with grace and compassion.
Thank you. Andrew and Jacqueline.
I'll just say, I know this was kind of last minute, but I'm so honored to be able to be a part of this. It was a great way to spend some of my Saturday. I learned a lot, and just seeing all the people that are doing this work, it just refreshes my soul. So thanks for having me, Deshay.
Yeah, it's very informative. I'm really glad you guys let me be a part of this, and Jacqueline brought it up to me. Anytime that you want some extra insight from an EMS administrative kind of things, never hesitate to shoot me an email or give me a call, and I'd be more than happy to be a part of future meetings.
And thank you both for being here. Yes, it was some stress, but thank you both for being here so much. And Lisa.
It's hard to go last after all of these wonderful sentiments and speakers saying all the right things. It's hard to come up with new things. I just ditto what they say every time. But yes, grace, compassion, thank you. Remember, we're all human and we're all different and we're all wonderful and we're all imperfect. That goes for our agencies too. So we really appreciate the opportunity to get to talk today and to get to know you a little bit better, and look forward to the journey ahead.
Thank you, thank you, thank you. And a quick round of applause for our speakers. Oh my gosh, thank y'all so much. Yes. You've made my Saturday, so thank you. Real quick, I'd like to pass it off to Lee if he had any quick remarks he wanted to make before we make our way into the closing session.
Nope, I think we're all good. So we're just going to gather for about 10-15 minutes to close us out. So no, being on Zoom for a number of hours can be tiring, but would love to see everybody to say goodbye back in the big room. Yeah, head on there and we'll wrap up. Bye, everybody.